Good morning, good afternoon, good evening, wherever you are. Members of ADI, colleagues, researchers from all over the world, people living with dementia, carers, professional carers. You're all welcome to this conference. And what you are about to listen to is a very important roundtable. I asked the Daisy Acosta, a former chairman of ADI, and also the representative for the Dominican Republic, to lead this roundtable because I know how much she cares deeply about 1066. The roundtable includes the principal and original investigators of the 1066 project, and I'm not going to tell you what the project is because that is explained very clearly in the roundtable. But suffice to say that the project aimed to establish the levels of prevalence of incidents of dementia in lower and middle income countries. These benchmark studies, whose methodology was devised by Professor Martin Prince of King's College, was instrumental for us to start establishing the level of prevalence of dementia and being able to advocate to governments armed with this very important information at our fingertips at the time in which there was no data on dementia available. But why now? Why are we having this roundtable now? It is because last year and this year, two important new studies of figures of prevalence and incidence were published by the WHO itself and by an organization called HME in America. Whilst the figures in themselves don't differ wildly from the latest figures published by ADI in 2015, it is important that, in a way, they draw our attention to the fact that in many countries still there are no studies run on prevalence and incidence. And these studies are still necessary to our members, often to raise awareness with their government. They have a problem on their hands. And the first question they ask many times is, do you have the figures? What are the figures for my country? And so it is still the case that many members of ADI and many researchers approach us because they want to use the methodology. And for many years, we didn't really either encourage them to do so or really knew how to find the funding and help them conduct the studies. Now, in an ideal world, it is not our association that should do the studies. It should be the government itself of the country. The methodology is out there. And if the government are really interested, they could apply the methodology and fund it themselves. But we very much know that for many governments, not acknowledging dementia is still a big issue. And I know that many of you would like to know more about facts and figures. And as the roundtable will show you, for the people that did participate in the first studies, this data has been invaluable in their advocacy with the government. So without further ado, I will hand over to the roundtable. Without one last proviso, please listen to it until the end. Because at the end, I also asked Daisy and the principal investigators to have a discussion on possible funding. Many people ask me, where are we going to find funding for this? And the roundtable tries to answer that question and give some suggestions, both to researchers, but also to government, to where funding may be available. A final note, it is our intention at ADI to also start tidying up our own data that is still on a database that ADI owns together with Professor Prince and King's College, and to make good practice data around 1066 more available and more clearly findable on our website. So it's also with this in mind, I have suggested for this roundtable to happen. I think the roundtable is amazing. It contains the incredible story of 1066 and also some really, really critical points about why this has been such a landmark study. I know it's used all over the world. I recently spoke with someone from Colombia, for example, that was using it and that hopefully is assisting at this conference. And I didn't even know the study existed. I know the studies are all over the world, and I thank you all, those of you that are still conducting the studies. So thank you for me, and I hope that you will enjoy this roundtable. Goodbye.
My name is Daisy Acosta. I am the principal investigator of the 1066 Dementia Research Group in the Dominican Republic, and I will be chairing this table today together with my co-chair, Dr. Aquiles Salas, who is also the principal investigator of the 1066 in his country, Venezuela. And we want to welcome you to this table that promised to be quite good. 1066 was founded in 1998 during the 14th International Conference of Alzheimer's Disease International in Cochin, South India, under the leadership of Dr. Martin Prince. Since then, incredibly good quality data from low and middle income countries has been collected. And as 1066 has been part of ADI from its beginnings, this quality data has served to give the Alzheimer's associations around the world information scientifically based for them to raise awareness to governments and policymakers. And thanks to that, many dementia plans are developing in the different regions. Today we have all the PIs of the 1066 that are going to be talking today about the work that we do. And our first speaker will be Dr. Ana Luisa Sosa. Dr. Ana Luisa Sosa is a psychiatrist and PhD in epidemiological psychiatry. Her clinical and research work has been focused in geriatric psychiatry and dementia. She is the head of the Dementia Laboratory at the Institute of Neurology in Mexico. Ana has around 100 publications and 3,800 citations. She, of course, is the principal investigator of this group in Mexico. And Ana is going to talk to us today about the history of 1066. Ana?
Thank you, Daisy, for so nice presentation. And I'm very happy to be here with all the 1066 Dementia Research Group family. I'm going to talk about the history of the 1066 Dementia Research Group. As you can see, we have been working together for 24 years. Our name comes because at the time when Dr. Martin Prince started leading our group in 1998, the 1066 of people with dementia were living in low and middle income countries, and only 10% of the research on this topic was carried out in these places. The 1066 Dementia Research Group have done so far 3 phases of the study. The phase 0 was the pilot studies. You can see here the years that we were doing these different phases. In the phase 1, we did the baseline study. In the phase 2, the incidence studies. And the dear and last phase so far, the dear wave studies. Now we will see along this line the years that we were doing the different phases. Then here you can see the pilot studies, where the objective was the development and validation of culture and education for dementia diagnosis algorithm. For this phase, we published this article where we explain and we report the validation study of the 1066 dementia research studies. In this pilot phase, we have the participation of 20 centers in 9 countries with a sample size of 2,885 participants. Here you can see all the countries and centers that participate in this phase. After that, we were ready with the protocols for the 1066 Dementia Research Group, and then we start with the baseline phase for evaluate the prevalence of dementia and other chronic disease. We studied the impact related to disability, dependency, and economic costs. And then at this point, we did a nested RCT of healthcare carriers to caregiving interventions. In this prevalent phase, we count with the participation of 15 centers from 9 countries, and the sample size was of 14,960 participants. Here you can see the list of all the centers and countries. And then we continue with the incident phase. In this moment, we evaluate the incidence, dementia, stroke, mortality, risk factors, and the course and outcome of dementia and mild cognitive impairment. As a result of this phase, we published this interesting paper about dementia index and mortality in middle-income countries. And this incidence phase, we participate 10 centers from 7 countries, and you can see here the sample size and the person years of follow that we got with this study. In the middle of the incidence and the last phase, we did the in-depth, that is a qualitative study with the objective was to evaluate the impact of need for cares on household where a person with disability was living. And then we did several publications as a result of this study. One of the publications you can see here in the right side of this slide. For this qualitative study, only 2 countries of this group participate in this phase for the in-depth study. And now we can see the last phase that we have done so far, that is the third phase that we finished in 2019. In this last 2 years study, we participate 6 countries and 9 centers, and the sample size was of 13,000 participants. Then, continuing working with this group since the beginning, we have had several challenges. One is that we start from zero, but with the enthusiasm and the leadership of Dr. Martin Prince and all the PIs that you know that we are participating in this study. And an interesting thing is that we start without funding. We pay the pilot study for our pockets. Then, as you can imagine, that the coordination of all these centers is not easy, but Dr. Martin Prince and his team, among them Dr. Cleusa Ferry and other colleagues, they were contributing to the coordination of this group. And the fieldwork was challenging. And then we had no predictable scenarios, as in China, one rural area changed to urban. In Peru was a earthquake, but we have several achievements. We became researchers thanks to this study. We learned to do research. The 1066 Dementia Research Group have demonstrated that the collaborative studies can be done successfully in our region. Generation of high-quality data was generated in low and middle-income countries. We increased the local capacity of each center, and we had 4 PhDs at King's College London supported for this study, and the data generated has used for the generation of local change by policymakers. We now have a plan for dementia for several our sites. Thank you very much for your attention. Here you can see the 1066 Dementia Research Group web page. Here is the address, and all the data generated for this group is open data available. Other researchers interested and invited to request the data for publications. Thank you very much.
Our next speaker will be Dr. Juan Llibre. Dr. Llibre is a professor of internal medicine in geriatric medicine at the Medical University of La Habana School of Medicine. He obtained his MD in 1983 from the University of La Habana and a PhD in 1998 from the Medical University of La Habana, and a second PhD in epidemiology at the King College of London in 2012. He has been published for more than 85 articles in the last 3 years and 3 books in dementia and mental health. He has been extensively involved in dissemination of research for public awareness and public policy in Cuba and Latin America. Dr. Llibre will talk about the 1066 methodology. Well, Dr. Llibre, welcome to the roundtable.
Thank you very much for the opportunity to participate in this session about the 1066 Dementia Research Group a global program addressed to study the epidemiology and the impact of dementia in developing countries. My presentation is about methodology of the 1066 Dementia Research Program. The 1066 pilot study started in 1999 in order to investigate the potential for education and cultural fair one-stage dementia diagnosis. In order to do that, several instruments for diagnosis of dementia were combined. A clinical structure interview the geriatric mental state, which apply a computerized algorithm, the HCAT, in order to give information about a comprehensive clinical assessment. Also, a screening measure the community screening instrument for dementia. We also measure the verbal fluency using the SERAT animal naming and also the 10-word list learning delay record. This algorithm or this pilot study were carried out in 26 centers in Latin American, Caribbean countries, Africa, India, China, and Russia. In each center, we recruit 120 participants of 65 years and over, 30 people with dementia according to DSM-4 in a slight or moderate state according to the clinical dementia rating scale, 30 people with dementia, 30 people with high level of education, and 30 people with low levels of education. The inclusion criteria also 65 years and over, living at home with an informant, and case status confirmed by independent clinician and interviewer blinded to a status. We studied approximately 30,000 participants from India, China, South Asia, Latin America, Caribbean, and Africa, and the same proportion of people with dementia, depression, high education control, and also low education control. Then we developed an algorithm using a logistical progression for independent predictor of dementia cases, including a cognitive test, an informant interview, the geriatric mental state, which apply the HCAT algorithm, and also the SERAT 10-word list learning delay record. Split half the procedure, a logistical regression model developed from one half of the data set, and the regression equation applied to other half. The discriminability of the algorithm in all centers was approximately 94 the sensitivity for dementia diagnosis, and also the false positive rate 15% for depression, 3% for high education, and 6% for low education. The validity of the 1066 dementia diagnosis, as I previously mentioned, developed and validated in 26 centers in Latin America, India, and China, with the further validation in Cuban population-based surveys, where all participants were interviewed by polyclinic psychiatrists and physicians, and the agreement with the clinician diagnosis was better for 1066 dementia than for the DSM-4 computerized algorithm. DSM-4 have a low sensitivity, particularly for mild to moderate cases. The predictive validity established also in India. In India, we found a higher mortality in those diagnosed with, according to this algorithm, with dementia, a cognitive deterioration, an increase in disability, and also a progression of need for care, 20% at baseline and 80% at fallout. The validity of the 1066 dementia diagnosis is, as I previously mentioned, based in a cognitive screening instrument, a cognitive test, 10-word list learning delay record, a community screening informant report of impaired memory and functions, and also a geriatric mental state that classify case as well, depression, dementia, and also anxiety and psychosis. What is dementia 1066? Is a validate cross-cultural against DSM-4 dementia diagnosis, and in our opinion, is a broader, more inclusive outcome than DSM-4. 1066 interview package includes two parts. One part is address to participants, approximately the interview is long, approximately 45 to 90 minutes, including the community screening instrument for dementia to the participant, the geriatric mental state, the 10-word list learning, and also an structured neurological examination, the neuro-S, that is exhaustive, is an exhaustive neurological exam. And also an interview to the informant lasted approximately 10 to 14 minutes and included the history and the etiology and subtypes dementia. And there are other instruments like the socio-demographic and risk factor interview, the HUDAS, in order to measure disability. We also studied the use of surveys for people with dementia and their family, and also the behavioral and psychological symptoms of dementia using the neuropsychiatric inventory. This is the 1066 protocol. It's, as I previously mentioned, a one-phase study, door knocking, a cognitive test, clinical interview, socio-demographic and risk factor interview, an exhaustive physical and neurological exam, blood test, including the ApoE for a marker for a genetic marker for dementia, and also an informant interview. Finally, the diagnosis included the 1066 dementia diagnosis, the DSM-4 diagnosis of dementia, and also DSM-4 and ICD-8 diagnosis of depression, other mental illness, and also other physical illness. Then we carry out the baseline study, 21,000 participants, 15 sites, 10 urban, 5 rural, from 11 countries, including Cuba, Dominican Republic, Mexico, Peru, Venezuela, Puerto Rico, Brazil, and interview blood and DNA. India and China, interview, and Nigeria, and abbreviated protocol, and a pilot in South Africa. And thank you very much to all our colleagues of the 1066, Professor Martin Prince, that he created this algorithm. Thank you very much.
Well, our next speaker will be Dr. Ivonne Jimenez. She's a PI at the 1066 Dementia Research Group in Puerto Rico. She's going to talk about 1066 and international studies. Professor Jimenez obtained her MD internal medicine degree at Puerto Rican University, and then in geriatric specialists of Mount Sinai Hospital of New York. She is certified by the American Board of Internal Medicine and Geriatrics. She has been director of internal medicine department at the Puerto Rico University during 11 years. During those years, she has been mentoring students, postgraduate students, and specialists in geriatric and internal medicine. She has participated in several research projects of Alzheimer's disease, both nationally and internationally setting, mainly early family Alzheimer's onset with Columbia University of New York. She is part of the CADAS study of Berkeley University and the New Finger LATAM in Puerto Rico. Please give a welcome to Dr. Ivonne Jimenez.
Hi, thank you, Dr. Aquiles. It's a real pleasure for me to be participating in this important meeting today in this Congress. I am the PI of the 1066 in Puerto Rico. My topic is about the 1066 protocol and international harmonizations. 1066 pilot studies have been carried out by 28 research groups in 18 countries. The epidemiological studies are still available in at least 14 countries, including countries with abbreviated protocols. The 1066 Dementia Research Group includes 30 research groups in 20 different countries in Latin America, the Caribbean, India, Russia, China, and Southeast Asia. 1066 studies are being conducted worldwide. Here you can see the places where the inception cohorts were done and the sister studies. In this article published at the International Journal of Epidemiology, we can see the cohort profile of the whole 1066 study. There is some debate about the best criteria for dementia diagnosis, and the most widely used criteria in epidemiological studies has been the DSM-4 in several versions. However, there are other proposed criteria that claim to be cross-cultural and more accurate for populations with low levels of literacy, such as those we have used in the 1066 study. In this article in Dementia Neuropsychology 2019 that was published by Dr. Teusa Ferry and her colleague, there is important information that says that the 1066 studies have made a huge contribution to the understanding of dementia in Latin America and other low middle income countries, and have the advantage of being harmonized, adopting the same diagnostic criteria across 6 Latin American countries. Another important contribution of the 1066 is that they are conducting or have already conducted new prevalence studies in the same catchment areas as the one conducted in 2000, which will allow them to show changes over more than a decade in different parts of Latin America. There is an NIH-funded initiative called HCAP Network, Harmonized Cognitive Assessment Protocol Network, with many participating studies. We have representation from many different countries in this group that has been meeting several times already. From Mexico, we have the Mexican Health and Aging Study. From United States, the HRS Health and Retirement Study. In England, now we have the ELSA, English Longitudinal Study of Aging. In China, the China Health and Retirement Longitudinal Study. In India, the Longitudinal Aging Study in India. From South Africa, Health and Aging Study in Africa, Longitudinal Study of In-Depth Communities. Chile, the Social Protection Survey. From Europe, Survey of Health, Aging and Retirement in Europe. Ireland, the Irish Longitudinal Study on Aging. Northern Ireland, cohort for the Longitudinal Study of Aging. The Korean Longitudinal Study from South Korea, and the new study, Caribbean American Dementia and Aging Study called CADAS. Here we can see, as Dr. Ana Luisa was explaining and Dr. Llibre, that since the beginning of these waves, we have been able to publish data from the same catchment area in 3 different times. We have been comparing all this data with other studies using this harmonization network. The 1066 Latin America and US HRA's harmonization means the cross-country comparison shows harmonized analysis of dementia determinants and societal costs across these populations, as well as comparing with the US HRS and harmonized cognitive assessment protocol HCAP data. The new study CADAS will enable substantial advances in estimation of dementia prevalence levels in these Latin American populations relative to those in the US using instruments harmonized with the US HRS. We have been evaluating all the instruments we use so that they can be harmonized with these other studies. Studying risk factors driving dementia prevalence in Latin American populations and comparisons across populations to simulate how prevalence could plausibly be different if social circumstances change is another benefit of this new study. We think this CADA study is an NIH-funded initiative, and Dr. William Doe is the PI, and it represents the 4th wave of the 1066 with an emphasis on data harmonization with other national and international studies. The main difference in this new wave is that we will be able to expand our previous catchment areas and will use a randomized sample of the whole country in each of the ones participating. We are really looking forward to new data, enabling us to move on with 1066 dementia research worldwide. Thanks for your attention.
Thank you very much, Ivonne, for such a nice presentation. I am really proud of the 1066 work. As I hear you guys, I am really impressed looking back and see all that we have done. Our next speaker is Dr. Mariela Guerra. Mariela is an MD, PhD at the King's College London, and she's a knowledge psychiatrist, professor at the University Cayetano Heredia in Peru. She is the assistant clinician at the Memory Center, Depression and Related Disorders. She's founder, volunteer, and president of the Scientific Committee of the Peruvian Alzheimer's Association. She's the PI of the 1066 Dementia Research Group in Peru and has many articles and books published. Mariela, please.
Thank you, Daisy. I am a Peruvian researcher, PI of the 1066 Dementia Research Group, and as such, I will briefly point out the impact of the 1066 in the Latin American region. For Latin American, there is a before and after 1066. Before, the epidemiological data related to dementia came from studies done in other realities, especially from high-income countries. An example of this is the Eurodem study, very famous, of course. In the Americans, in that time, it was believed that outside North America, dementia was a very rare condition. Globally, this was seen to the extreme that population studies reported that, for example, there was no dementia in older adults in Nigeria. So there is a before and an after. As we have seen, the methodology is one of the main strengths of the 1066. So with this, 16 years ago, for the first time, Latin America was able to have its own epidemiological data on dementia, and also in other conditions related to the mental health of the elderly. Generating all of this information in our countries, a great impact on public health, social policies, carers, patients, and even inspiring new studies groups around the world, as have been mentioned by Dr. Ivonne Jimenez. In this picture, we have dementia, and the surprise was that with the protocol of the 1066, numbers were higher than those that were found when we use the classic DSM classification of the United States. Since its inception in 1998, over 200 1066 papers have been published, not only on prevalence incidence, but on topics related to care, mortality, risk factors for dementia. Moreover, there are publications on other mental health conditions in the elderly, such as depression, anxiety, nutrition, alcoholism, among others. So really, this project, this group have studied a lot of factors and a lot of problems in our countries. This is a classic paper related to the population attributable fractions for potentially modifiable risk factors. And in this investigation, what we can see is that the data from Latin America come from the 1066 studies. So we know now that there is a lot that we need to be done to protect our people, our region, with many research that we are carrying on. Currently, 3 new risk factors for dementia are cited: traumatic head injury, alcoholism, air pollution, factors highly prevalent in Latin America. And we are sure that the results from the 2-year life 1066 study, now finished and analyzing now the results, will contribute widely with information to our region. Finally, we have to say thank you to the 1066 Dementia Research Group, to the leader, Dr. Martin Prince, because many of our Latin American countries have been benefited from the 1066 data, allowing us to propose to develop national dementia plans, programs, and also generating change in the lifestyles of adults and older adults. Thank you very much.
Thank you, Mariela. The truth is that it's been a tremendous impact of 1066 in Latin America. And thank you also for mentioning our randomized control trial for caregivers intervention. I think that was a big step that we did at the beginning of our studies. Thank you very much, Mariela. And our next speaker are Professor Yueqin Huang, and I have to mention Dr. Xiaori Liu. They are both from 1066 China. Dr. Yueqin Huang is a psychiatrist, epidemiologist, and director of the Division of Social Psychiatry and Behavioral Medicine at the Institute of Mental Health, 6th Hospital of Peking University for Teaching and Research. Dr. Yueqin is the principal investigator of the 1066 Dementia Research Group and of many collaborative international projects in China. She has published 355 papers and is editor-in-chief of 8 books. And Dr. Liu is associate professor at the Division of Social Psychiatry and Behavioral Medicine Institute of Mental Health at Peking University. She has a rich experience on research projects in social psychiatry and has been involved with 1066 since 2003. And she calculated the cost of dementia for 7 low and middle income countries, finding important drivers on cost. Dr. Yueqin Huang, please come to the podium.
Thank you. Thank you, Dr. Acosta. My name is Yueqin Huang. I'm from the Institute of Mental Health, Peking University. I'm talking about 1066 dementia study in China. In recent 10 years, the 1066 Dementia Research Group has conducted population-based surveys of dementia prevalence, incidence, and impact in several low and middle income countries. And China is one of the project countries. The China team is from the Peking University. The photo show the old generation, and now Zhao Rui and I are the second generation, and these are our study teams. So the study from almost 20 years ago. So in San Domingo, Dominican Republic in 2003, we started collaboration, and more than 10 years we meet in Beijing, China in 2016. We worked for so long and have a very good result to share each other. The findings from the series of 1066 studies will influence the health policies for older population in China. This picture shows we produced a movie for disseminating knowledge of dementia in China. Regarding the impact of 1066 dementia study in China, actually we including internationalizing study instruments on dementia and establishing study teams, including psychiatrists, epidemiologists, sociologists, and other related sectors, and enlarging study setting from clinic to community. The most important study as we apply 1066 study instrument package in China Mental Health Survey. This is the first nationwide epidemiological study on mental disorders in China. It influenced the psychiatry world in a psychiatry field in the world, and also in future, it will impact research and the policy making on dementia treatment and intervention. So we already published our study in Lancet Psychiatry. We introduced our 1066 dementia diagnostic package in this paper. So the psychiatry world understand we use 1066 66 dementia instruments in the largest study in China. And when talking about research and the policy making on dementia treatment and intervention, there are guidelines for the diagnosis and treatment of Alzheimer's disease and other dementia. And for National Mental Health Work Plan from 2015 to 2020, then currently the 16th 5-year plan for healthy aging and call for public education activities to care for the elderly with dementia, and call for prevention project to improve the prevention and care. Talking about the impact of Asian country, our 1066 study encouraged new study. First, as we know, India is one of the 1066 project countries, and they are carry out the study 1066 dementia study, longitudinal aging study of India, and the study of global aging. And for new research programs in other countries, in Singapore, a study, the program is well-being of the Singapore elderly population study in Vietnam. They provide training, and in Pakistan, the program is validation of the short version of the 1066 dementia diagnosis. And in Lebanon, the program is Arabic validated 1066 Dementia Research Group diagnostic tools. And in Korea, the program is Association of Great Stress with Dementia. And in Iran is validation of the 1066 Dementia Research Program dementia diagnosis. So that means our 1066 study has some impact in Asian countries. Then we are still working hard for it. Then I think we are still want to keep our collaboration with all 1066 group, and also we're happy to share our result with all of our study teams. Thank you very much.
Thank you, Yueqin. Excellent presentation, and it's glad to see how many Asian countries are really using 1066. Thank you very much. Now I will open the table for discussion as Dr. Richard Uwakwe, our PI, a principal investigator of 1066 Center in Africa, had trouble connecting, so he excused himself. So let's talk about what is next for 1066.
Hello, Daisy.
Richard, great to hear from you, Richard.
I just connected. I've been having great difficulty with network. I just got in.
Excellent. Excellent, Richard. Can you tell us a little bit about the impact of 1066 in Africa?
Okay, because I've been having difficulty with network, I will just summarize it this way. The first impact is that it has increased awareness of people's studies into dementia. And I'm happy to announce that because of the 1066 research, we have been able to send postgraduate students as fellows in some American universities. So right now, somebody from my department is at the University of California because of the 1066 studies, and is applying for a pilot that we are going to use the 1066 approach to do in Nigeria, and we're making very good progress. In the same way, in our university, a number of people have taken interest, and we have got a lot of volunteers. So if you look at our publications now, a number of people have taken interest and that using the 1066 approach to community studies of dementia in this part of the world. But our greatest joy, as I said, our ability to get postgraduate students to go for fellowships in American universities. Thank you very much.
Thank you, Richard. It's good to hear that. And with you there, I am sure that 1066 will be expanding further in Africa. So now we are open for discussion. And the first person I want to address is Wendy Weidner from Alzheimer's Disease International. Wendy, how can ADI help 1066 to go forward, for sustainability, to go on?
Thank you, Daisy, and thank you everybody for this fantastic overview of the breadth of work that has been done over the years in 1066, and it's really inspiring to see what's been done and how it's grown. And I think with ADI, we're very much about connecting and ensuring that there's a sustainability for the kind of research that's done. And I was very encouraged that in a number of the presentations today, there was a direct link with some of that epidemiological data that was collected and influencing policy, and then bringing that into national plans, which creates that framework to make care better. And that is exactly what ADI would like to do. We would really like to invigorate this even further and create a platform where we can continue to get 1066 moving in different countries, connect to different researchers, build capacity amongst researchers, but ultimately to influence policy and to have more plans. It was quite interesting to see the slide that showed that direct connection between 1066 and dementia plans. So it's fantastic that we're having this discussion, and it's going to link to an ADI conference, because what we'd like to do is increase, spread the word about 1066. It's been around for so many years. I was so interested when Ana Luisa talked about the history, and now it's talking about the future. And I think Ivonne was in her presentation talking about that phase 4. So ADI is here. We'd like to reinvigorate that onto our website and start making those connections to more projects. So thank you, Daisy, for giving me the opportunity to talk.
Excellent, Wendy. We don't expect less from ADI. And definitely 1066 is part of ADI. And most of our plans in Latin America are based on the 1066 work, definitely. Because as Mariela was saying, there was a before and an after 1066, at least in this region. But if there is no money, there is no mission. So Dr. Doe, you are here. Help us and tell us, where do you think will be the best sources for us to go for funding to continue our work?
Well, thank you, Dr. Acosta, for inviting me to contribute comments to this distinguished roundtable as we explore how to build on this impressive 24 years of 1066 and move it into the future. As we think about funding, of course, the key is to articulate the scientific innovations that we want to make with each new effort and to align it with the priorities of different funders. So I can speak most directly to the United States National Institutes of Health that has funded much of my own research and our ongoing CADAS study that was mentioned earlier, and is funding many other projects around the world that are exploring in different global settings Alzheimer's disease and related dementias. As Dr. Jimenez spoke to the HCAP network, the Harmonized Cognitive Assessment Protocol that has been integrated in many of the health and retirement studies around the world. This has been a major thrust of the US NIA, and they will continue to be investing in this. Now, as we think about the NIA priorities, they are going to prioritize basic science, including the epidemiology of dementia, as we continue to document the changing prevalence and incidence, risk factors, implications for health systems and family caregivers, innovative opportunities such as with COVID, thinking about interactions of COVID that the NIH is funding new studies right now. With 1066 in particular, the innovative opportunities for science exploiting the long panel, where you have followed individuals now for well over 15 years, which is really such a unique scientific opportunity to build on as we understand the longer term determinants of dementia, as well as the rates of cognitive decline that we can document with these incidence studies. So I think that there scientifically is so much exciting opportunity. NIA will also fund prevention intervention studies. If they're innovative, they're strongly justified and well-powered and have generalizable implications. Now, NIH is also looking, though, increasingly for national governments to be cost-sharing these efforts. So I think as a group, we need to continue to educate our governments and make the case for their investments in continuing in these important cohort studies, such as 1066. So there are opportunities. There are wonderful examples of governments that have stepped up and are now contributing major funding to such cohort studies in low and middle income countries. So I think this is something that we definitely need to do. And then we have non-governmental funders. There have been foundations such as Wellcome Trust that, again, have been so instrumental in pushing forward the science, similar to NIH's priorities. And then we have funders such as the Alzheimer's Association, which has been important in international studies as well, including for funding prevention studies such as FINGER, et cetera, as that expands worldwide. So, you know, we need to really acknowledge and thank and continue to work with those funders. And then as we move beyond both the epidemiology and prevention, as Wendy just spoke about, moving to our national plans for how we're going to address the needs of caregiving, then again, we need to work with our national governments, are going to be key to integrate these studies, the 1066 studies, with the epidemiology, with the intervention studies, with the preparedness studies. We have new opportunities. So there are funders such as the Davos Alzheimer's Collaborative, which is funding a series of studies around the world that are going to be enhancing healthcare system preparedness and looking at innovative models for this. So this is really exciting opportunity now where we have non-traditional funders who have recognized the needs that we have, and we can go to those funders and make the case that 1066 is going to provide a platform for really first-rate science, and science that's going to have a real impact on societies and the individuals, persons living with dementia and their families. So again, congratulations to everyone involved in 1066. It's a really exciting time. And our job now is to make the scientific case. And I think we can do that. So thank you.
Thank you very much, Dr. Doe. That is really hopeful, all those things that you have told us. I think we have a good chance of getting funded and continuing our work. One last question, because we don't have more time, But and this is open to whomever want to answer. What do you think should be our next step? Shawri, what do you think, Shawri?
Thank you, Daisy. I think the most important thing is we should be together. I can't say forever, but keep as long as we can, because we actually had the collaboration from very earlier, and nowadays it is really difficult actually to find financial support for us to continue the research. Thanks for Dr. Dao very much, and give us a rich information about how can we find some support. And I think the most important thing is we can collaborate to try to do some application. And also we can think about if we can't do together, I mean, all the centers together, maybe some of us can do some small collaboration. If that's possible, it's also fine. And also, I think the most important things after the epidemiological survey is we try to think about how we really can help the caregivers and how we can really help the patients. As in China, actually, after we did the epidemiological survey, we also do some project. One is to provide helps for the carers, try to train them helping carers to care, which is actually a very important component actually for our 1060 family. And the other thing is, I'm not sure if you remember, we actually had the training for the cognitive stimulation therapy, which is a non-pharmacological intervention for dementia patients with the mild and moderate stage. And we actually in China, in Beijing, we applied several funds with Professor Huang together, and we try to provide the prevention for older persons. And they are very happy to have this project. And also, besides Beijing, we also provide the training for other cities, and we kind of encourage them. And currently, I had a grant, a very small grant, and try to think about if we can do something electronically, which means that because when I provided the training for the cognitive stimulation, especially for the persons from community, this is quite difficult to follow, and there is so many materials. And then we think we can, with a kind of package, and maybe can scaling up this kind of intervention. I think that will be much better. So for all of us, I think I encourage you, I mean, besides the cohort, which is really important, we can try to think about do some intervention for the older persons, also for the caregivers. That's all. Thank you very much.
Thank you, Dr. Liu. Excellent intervention. Anybody want to add to what Dr. Liu just told us?
Yes, I would like to say some words. As I mentioned, the 1066 Dementia Research Group, it has already been 14 years since it gave its first signs of life. As you can see, except for Shawi, all the researchers who started the group, we are already older adults. We were younger, believe me. And the challenge is to consolidate the continuity of the work of our group, integrating young researchers as Jorge Llibre and Luisa Acosta that are today with us and that have participated in the preparation of this symposium. This to ensure the continuity of the work of the 1066 Dementia Research Group. This will guarantee the renewal of energy and the emergence of new proposals. Among the immediate challenge is the publication of data from the last phase of studies, promote the use of our data for other investigators, and obtaining new funding to continue working. Thank you, Daisy.
Thank you, Anna. You couldn't have said anything better. You see, we are preparing a new wave of 1066 young people because, as Anna said, we age in 1066. So thank you very much. I think we all want to say something. Anybody who has something very quick and fast to say?
Daisy.
Yep.
Hi, it's Achilles. Okay, having a real pleasure to share with you and to find all my fellow friends at this important and very deep information about our group. It should be a great moment for the group to continue, and we will together go forward to still doing our best. This is really a great group. Thank you.
Thank you very much.
Briefly, 1 minute. We need to focus, Dr. Doe, we need to focus on Africa because we don't have too much information about that. And in Latin America, considering that it's a multicultural, multi-ethnic region with large social gaps and inequity, we require to make research in different directions, cognitive assessments of indigenous rural populations with appropriate instruments, among other studies. So we need a lot of work to be done in our regions.
Well, thank you very much, Mariela, and to all the PIs of the 1066 Dementia Research Group. Thank you to Alzheimer's Disease International. Thank you to Dr. Doe. And thank you to Dr. Martin Prince for forming this group. We are a family. Thank you very much, and I will see you in London.